talk. Our next speaker is Dr. Dave Skaggs, and Dr. Skaggs is the chairman of pediatric orthopedic surgery at Children's Hospital Los Angeles and is a professor at the University of Southern California. Dr. Skaggs is going to talk about, as you can see, supracondylar humerus fractures. Thanks, Dave.
I have no disclosures except I make very little money on textbooks. So first we're going to talk about indications for surgery. A type 1 fracture in which there's no significant displacement, the anterior humeral line goes through the capitellum, is pretty much agreement that we treat that child in a cast for 3 weeks, no surgery is necessary, don't flex the cast more than 90 degrees. Type 2 fractures, in which the anterior humeral line does not touch the capitellum, there's a debate whether this should be pinned or simply close-reduced in a cast. And what some of the studies show us is if kids were just casted and not pinned, up to 50% of them had limited elbow flexion with 9-year follow-up. That's a pretty impressive study because there's so much follow-up, and we have to agree that remodeling about the distal humerus really doesn't take place reliably. And other series have shown that when you try to treat type 2 fractures in a cast alone, up to 1 in 4 of them lose reduction, and if you don't get back to the OR in 2 weeks, you're probably going to have a poor result. Now, the other studies that we've seen is in a supracondylar fracture, if you flex the elbow more than 110 degrees, you can lose the pulse, and you can increase compartment pressure. So I think to stay out of trouble, you probably never want to flex a supracondylar fracture more than 90 degrees. Instead, put pins in it. And so usually type 2 fractures, close reduce, put a pin in it. I'd say the gray zone in my practice is if a child is 3 years old or less and the anterior humeral line almost touches the capitellum, well, maybe we'll treat that closed without pins, but that's the gray zone. Now, a type 3 fracture, there's very little argument here. You just fix it. You know you got to fix it. You know you got to go to the OR and fix it. Some of the controversy now is it emergent? And you should operate soon if there's any problem with perfusion, pulselessness, ecchymoses, as you see in this fracture, skin puckering, where the proximal fracture is attached to the skin, or a concomitant forearm fracture, which might lead to a compartment syndrome. Get out of bed for those. Now, let's talk about surgical technique. And this may be a funny slide to put under surgical technique, but I really think the first and most important thing to do is a good examination of the nerves and the vascular status. Because if you have a nerve injury or vascular injury post-op, you need to be pretty confident that it was or wasn't there pre-op, or you could end up in a tough situation. Now, this is going to be very practical. How to set up the room. I like to sit, right where you see the stool there, so you can look straight forward and see the fluoroscopy screen, and I have the resident sit at the end of the table. With little kids, when you keep trying to pull the arm out to get a good image, and sometimes the head's about to fall off the table, make your life easy and put the head on the arm board to begin with, so you can't pull the head off, and it's easier to x-ray the elbow. Step number 1 is traction. In this case, my arm is in the armpit with the white arrow. The resident is pulling on the arm, and note how the elbow is flexed up a bit. I think you want to keep the elbow flexed while you apply traction, or else you could imagine that the artery and nerve draped over that proximal fragment could be injured. So flex up the elbow while you're applying a little bit of traction. Now, reduction, first off, we never hyperextend to protect the neurovascular bundle. Slowly flex up, possibly while applying some traction, and push forwards with your thumbs. In this case, the intact posterior periosteum is our friend. And if the fingers almost touch the shoulder, you've probably gotten a good reduction, at least in the sagittal plane. If the fingers are nowhere near there, you know you haven't done a reduction. Now, if you don't have a reduction, I think it's worthwhile to spend 4 or 5 minutes not only in traction, but also in the milking technique as described by the group from Utah. Try to push with your thumbs the brachialis muscle off of the distal humerus. And it sometimes gives this wonderful feeling, kind of popping sound as the muscle goes through the bone pops into place, and you've avoided a closed reduction. In my institution, we only do an open reduction, I'd say about 2% of the time, and I attribute that to taking a fair amount of time with the milking technique. And what we're trying to do is balance two knife edges, which are kind of thin, and this is a little bit difficult to balance this. Remember that periosteum is our friend. In a posterior medially displaced fracture, it's probably torn laterally, so pronation helps. What the textbooks don't talk about too well is if it's a posterior laterally displaced fracture, the periosteum is intact laterally, so supination may help. So if pronation doesn't work, try supination. We want to assess that the anterior humeral line crosses the capitellum. Bauman's angle is at least 10 degrees. And a little translation from one side to the other is okay. Translation will remodel. Look at the obliques to make sure that the two columns are lined up okay. And I have to admit that I'm rather lazy. Once we get the reduction, I will tape the arm into place lateral entry pins through the lateral side only, and then, most importantly perhaps, is stress your fracture under live imaging. If the fracture is going to fall apart, we would love to know that it falls apart right in front of you, right at that time, while you can fix it rather than 1 week later. And if there's any question, put in a third pin. Perhaps one of those pins aren't perfect. A third one would help. I will put sterile felt right on the skin to help prevent skin problems. Then sterile foam. Notice there's nothing circumferential. We want to allow for swelling to take place underneath the cast, so you don't have to split the cast in the middle of the night. And now we're not holding reduction by flexing the elbow, so allow the elbow to extend to 45 or 60 degrees. The pins are holding reduction, not the cast. So there's some technical errors that can take place, and two centers got together to look at errors, and we found out that the most common errors was one of the pins was an air ball. It didn't catch the proximal fragment. Or it ran up the shaft. It really didn't get good cortex. Or the two pins were so close together that they didn't function biomechanically as two pins. Of course, the worst thing is cross pins. We know that that's bad in any fracture. So the failure analysis was interesting, and that all the failures only took place when there were two pins. So by using 3 pins, we're probably assuring that even if one of them was an air ball, 2 pins are probably good. So let's look at the positives. What we want to do is separate the pins at the fracture site, make sure that there's enough bone at those corners, and if there's any question, use 3 pins in a type 3 fracture and probably only 2 pins in a type 2 fracture. And remember, with a type 3 fracture, you always treat it surgically. Most of the time, try for a closed reduction. If you don't get the closed reduction, I would consider the possibility of an open reduction through an anterior approach. Most orthopods are hesitant to use this if they don't have a lot of experience, but the danger is the artery and nerve are right there, and the scar heals wonderfully right along that transverse crease. The only thing you don't want to do is use a posterior approach, because the trochlear blood supply is an end artery. In my town, there was one guy that used to open them up all posteriorly, so I have a lot of patients that look like this with AV end of the trochlea, and that's a tough thing to fix. There's no real good answer there. Last topic is a type 4 fracture, and this is a fracture that can fall into extension, as you see in the left, or into flexion, as you see in the right. This is a very unstable fracture that the old textbooks say you should just open immediately. Here's one hint of how to possibly reduce it closed, is first do an AP imaging in the distal fragment, then do a lateral imaging and put the pins in the distal fragment first. And under lateral imaging, when you get it correct, just zoom the two or three pins across the fracture fragment, and you may, and in fact in most cases in our paper, avoid the need for an open reduction. And if anyone wants a very detailed description of this technique, it's in this book, or if you email me, I could probably just send you a PDF if you don't tell my publisher. And that should do this talk. Thank you.
Thanks, Dave. Well, that's really good, Dave. While everybody else is getting back on, I have a couple questions, and from some of the audience as well. So, you know, I've done a lot of supracondylar fractures, but I've never heard that champagne pop. Am I doing something wrong?
Oh, You don't really hear it. You more
Oh,
like
okay.
just
Something you
feel
feel.
it,
Okay.
or a feeling of the muscle coming over the
Yeah.
bone.
Okay, great. And you said that you said that you usually diverge the pins, but I noticed in one of your examples that they were pretty parallel. Do you still try to diverge them mostly?
Honestly, I picked that example intentionally. I don't think it's so important if the pins are diverged. I think what's more important is that they're separated at the fracture site.
Okay. Um, Scott, could you tell us what you do with a flexion-type supracondylar fracture, especially after your talk on nerve injuries and recently? How many times have you seen the ulnar nerve?
Well, if it's like a type 2 flexion type, we'll still try a closed reduction. And if it's a type 3 and it's displaced, then we often open them immediately and be careful of the ulnar nerve and then fix them percutaneous.
Yeah. Do you often see the ulnar nerve involved in that?
Yeah, it's yes. The answer is yes.
Yeah. So those are really tough ones. So just for the audience members to think about that as a big problem sometimes. Don, if you have a patient that has a displaced distal radius fracture and a supracondylar fracture, what do you do anything different on those patients? Say a type 3 supracondylar and a completely displaced distal radius fracture.
So we know that in the so-called pediatric floating elbow injury, where you have a supracondylar fracture above a forearm or distal radius fracture, that's a pretty significant injury, and there's indeed a real risk of compartment syndrome. For that reason, I think that's a good indication for surgical stabilization so as to avoid the need for a circumferential cast. And in our institution, both fractures would get reduced and pinned.
Does it matter which order you do them in? Do you have a way that you decide?
So personally, I will reduce the radius first, and then I will do the elbow second. My rationale for that is taking notes and learning a lot from Skaggs and the other guys. We know that that so-called central column pin is very important, and I found that with that more central column pin, if the olecranon fossa is obliterated, you can't extend the elbow, and actually imaging and positioning for the radius reduction I found to be much more challenging. So I will actually do the radius first and do the elbow second.
How about you, Dave and Scott?
I feel like I just learned from Don on that one. I think I'll do what he said.
Scott, how about you?
We're the same.
Okay, great. Now, you went to a lot to show us that you should put in lateral pins. Is there ever a place to put a medial pin? Is there some fracture pattern that you would say this one should have a medial pin?
Yeah, I've put in medial pins in cases of amputation because you know that you need more rigid fixation and you need to get motion. And if you have a fracture pattern that's more or less parallel to where the lateral pins would go, it's really difficult to get 2 or 3 pins. So in that case, I would use cross pins as well. I'd like to make a comment that I'm probably a little bit psycho on using lateral pins alone because I've seen in my institution one of the surgeons had a 17% rate of ulnar nerve injury because he was hyperflexing the elbow when he put in the medial pin, which could, of course, injure the ulnar nerve. But I think as long as you extend the elbow after putting in a lateral pin, you could probably put in a medial pin fairly safely if people, have experience with that and they've done okay.
Great. One other question is if you have, Don, you kind of mentioned this about the risk of a compartment syndrome. Do you ever, in a kid that has a floating elbow, some so-called floating elbow, do you ever do, how do you take care of measuring the compartments if they're in a cast?
Right, so that speaks that's the argument for reducing them and pinning them so you don't need the cast to hold your alignment. Those patients, for us, I think it makes sense either to splint them and observe them in the hospital. I think there was a question in the chat about an automatic prophylactic fasciotomy. I probably wouldn't do that, but I think that if both fractures are fixed and you have a very swollen patient at risk, putting a posterior slab on and watching them in the hospital until you know they're safe makes a lot of sense.
Okay, very good. Well, thank you very much. So Roman is going to put on that poll that I don't think we ever got finished after the first question. So if you could all take a time to complete this. So if VuMedi really want to know whose audience is. All right, so it looks like we have most of the people on tonight are general orthopedic surgeons, and we only had one question about treatment, and that was about treatment of a displaced radial neck fracture. And even after Dr. Kozen's talk, you all chose to do, most of you want to do closed reduction, which I don't blame you. It's probably the best way to go. So, and a lot of you are very experienced in treating a lot of pediatric elbow and forearm fractures. So thank you all for coming here tonight.